Thank you very much for the invitation. I just want to say a special thank you to Dr. Adams without him, none of this would have been possible, at least for me. So I've been asked to talk about management of arrhythmic mitral valve prolapse. I decided to take it from the perspective of working with the surgeon. So a little bit of background, PVCs are very common in patients with mitral valve prolapse. About 60% of patients have some burden of PVCs. If you look at MVP sudden death survivors, 100% of them have a history of PVCs in the background. And if you look at all comers of patients with mitral valve prolapse, about 65% of them have some burden of PVCs with exercise. Importantly, about 60% come from the pap muscle, which we all know to correlate with MVP, but about 1/3 of them arise in other areas, such as the outflow tract, the AMC, the mitral annulus. So they're pretty common and their locations do vary, but most of them are somehow related to the mechanics of the mitral valve. So what is the effect of mitral valve surgery on PVCs? And we hear this a lot asked by patients as well, is it has a modest effect at best. It probably works best in younger patients, but on average, it only lowers your PVC burden by a few percentage points. It probably does lower your complexity of PVCs, makes them less malignant, but on the overall burden, it has a modest effect at best, and that's obviously based on a few retrospective analyses. So why does mitral valve surgery not have a significant impact on PVC burden? Well, number one is they can come from different locations. Patients can have multiple different morphologies. And number two is that they're likely due to more than just one mechanism. And I'll show you here, just as a reminder, when it comes to MVP-related ventricular arrhythmias, there's basically 4 types of arrhythmias you can get, so we should probably stop categorizing them all as ventricular ectopy. You can have PVCs, you can have monomorphic VT that's not scar-related, you can have scar-related VT, and finally, of course, ventricular fibrillation. And we put together this scheme a while back, which is our theory as to how mitral valve prolapse, by what mechanisms it leads to these 4 different types of arrhythmias, which basically are either re-entry related or triggered activity. Triggered activity is what you're used to seeing, for example, with isolated, outflow tract PVCs. So if you look at the spectrum of what an MVP patient sees, they tend to see a cardiologist, electrophysiologist, and a cardiac surgeon over their course of their lifetime. I'm not going to actually talk about risk stratification for patients with mild or moderate MR, or mild to moderate, because it's not really relevant to the surgeons. But we do things such as just monitor them if they have no scar, perform some form of risk stratification if they have the appropriate substrate, and sometimes obviously consider catheter ablation if it's just isolated PVCs. What I would like to focus on is where the electrophysiologist and the cardiac surgeon kind of start to meet in the middle. So if a patient has moderate MR and, for example, malignant ventricular arrhythmias such as PVC-induced VF, or a high burden of unifocal PVCs, you have 2 options. You could either consider a catheter ablation, or you can actually maybe consider the option of surgery plus minus ablation during the surgery. And that's usually reserved for patients who have lots of markers of disease. So I'll give you an example of that. This is a 35-year-old female, past ventricular palpitations. She's got a low PVC burden of 4.1%, at least 2 morphologies, only moderate MR. Someone put her on a treadmill. She had a little bit of NSVT. She had a cardiac MRI, pretty classic mitral angular disjunction of 1.3 millimeters. She had scar in the typical locations, and they recommended she have an ICD implant for high risk for sudden death. She came to us for a second opinion. You can see there on the 12 EKG, she's in ventricular bigeminy with likely posteromedial papillary muscle PVCs. So we actually offered her that first option of catheter ablation, 1, to treat the symptomatic PVCs, and number 2, potentially reduce her risk of a future life-threatening arrhythmia. And that's all hypothetical. There's no evidence to support that. So we actually performed 2 catheter ablations on her 5 months apart. PVC ablation number 1, it was RF radiofrequency ablation of the posterior medial papillary muscle. And then she had PVC ablation number 2, which was a combination of radiofrequency and catheter-based cryo of both papillary muscles. And then after both ablations, within 24 hours, her PVCs were back. So either we were in the wrong location or we were somewhere deep in the myocardium, or we just couldn't get our energy source to there. These are her Holter's post-ablation number 1 and number 2. You can see her burden of PVCs may be low, but she has almost a disgustingly amount of NSVT episodes on both of those Holter monitors. So we decided to put a loop recorder in her just to monitor, see how she felt, and if she had any symptoms. So this is an example of her loop recorder when she was chasing after one of her kids. And if you're not used to looking at loop recorders, that's occasional sinus beats and lots of ventricular ectopy. She basically lives in trigeminy when she's moving around at all. And she still has moderate MR. So the catheter ablation route did not work, so we actually referred her to Dr. Adams for consideration of surgery and ablation. She had a couple of very appropriate questions, which were, will the repair reduce her risk of sudden death? The answer is we believe so, but we don't have any prospective evidence to support that. Will ablation of PVCs reduce her risk of sudden death? We believe so if you remove the trigger, but again, we have no evidence to support that. And is adjunctive papillary muscle ablation at the time of surgery safe and effective? We believe so, but obviously you would need randomized data to prove that. So this particular patient underwent a mitral valve repair, tricuspid valve repair, and he ablated both papillary muscles. And this is just an example of her recent loop recorder transmission. She has had 0 PVCs and 0 NSVT for about 1.5 years since the surgery. So she's done great with that strategy, although we tried a less invasive approach first. So then you have, and obviously that one worked. Then next you have the one that the cardiac surgeon usually sends back to us, because we often send the moderate MRs to the surgeon, they send the severe MRs back to us. So the way I look at it is if you have severe MR, you either have complex ventricular ectopy, LGE, or FDG, at which point just go ahead with surgery, meaning there's already substrate there, there's already damage done. If you have malignant ventricular arrhythmia, such as PVC-induced VF, I do believe that surgery reduces the risk of future ICD therapies. And if you have frequent unifocal PVCs, such as you just have a lot of papillary muscle PVCs, consider surgery plus minus ablation of either a papillary or non-papillary source. So I just want to show you one example of a mechanism-dependent patient and why no ablation was performed. So this is a 40-year-old male. He had diagnosed with severe MR, mainly from palpitations, bileaflet prolapse. He was actually admitted to the hospital because of his palpitations, and this is an example of his 12-lead ECG. He just lives basically in monomorphic VT. Importantly, the cardiac MRI had no scar, so this is basically the equivalent of having lots of isolated PVCs, but in a row. And our thought was that no scar, no evidence of disease substrate, this is probably all related to mechanical traction irritating the ventricle. So this patient actually underwent just mitral valve repair, and this is the Holter 1-year post-op, 0 PVCs, and this is 4-year post-ops, 8 PVCs, so the equivalent of 0.0001. So identifying the mechanism of the PVCs of ventricular ectopy can often be helpful in coordinating with your surgeon. I'm going to show you one more example of a patient with severe MR and frequent unifocal PVCs in which surgery plus ablation was considered. So this is a 75-year-old male, posterior leaflet prolapse, severe MR, preserved LV function. He consulted with a cardiac surgeon. He was planned for mitral valve repair. He had frequent symptomatic PVCs. Almost every EKG was in bigeminy, going back at least a year. And this was all confirmed with a 4-week event monitor. And for very frequent symptoms, especially when he was exercising. So the surgeon sent him to us and asked to evaluate before surgery. This is an example of the 12-lead EKG. I know you're not necessarily used to looking at EKGs, but this is kind of a classic pattern for what we call AMC or aortomitral continuity PVCs. It has that QR pattern in V1, and it's an inferior access positive in the inferior leads. So we decided to send the patient for a hybrid PET MRI to see if there was any substrate that matched up with where we thought it was coming from. And you'll notice here in the left-hand portion of the screen, there is no scar in the ventricle, so there's no kind of chronic injury there. But if you actually look at the PET images, the only place that FDG uptake occurs is in the AMC region. So it's nice that it localizes what we believe to be inflammation with the source of the PVCs. So the question then came up is, how do you ablate these PVCs during a mitral valve surgery? I'm not a mitral valve surgeon, but they did tell me that it would be difficult to go under the ventricle and come back around. When we do this with catheter ablation, we go retrograde through the aorta, we hook up our catheter like a U, we swoop it over to the left side, we pull it up, and usually we can land on the AMC if after we're done mapping. But from a mitral surgeon approach, it's not as easy. So Dr. Adams decided to perform the cryoablation, but from the atrial side of the annulus, because we thought we were pretty sure where it was coming from. And this is just an example of this surgery. This will be short. Don't ask me to explain what those leaflets are. Here's the cryoprobe going in. We believe that to be just opposite the AMC on the atrial side. Cryoablation was performed. I believe it was a 2-minute lesion. And I'll show you one final picture afterwards. So this is a final picture of where the cryoablated tissue was in relationship to the aorta and the valve. So this patient, follow-up monitor was done about 6 months post-op, off all medications, including beta blockers. PVC burden was 1%. Routine transthoracic echo done 6 months post-op, normal function, trace MR. So that's an example of where kind of coordinating ahead of time actually allowed us to address this particular patient's problems. So in conclusion, we believe that arrhythmic MVP as a multidisciplinary and collaborative approach is necessary. Treatment of PVCs in patients with MVP depends on the burden, the morphology, the complexity, and the severity of the MR. Surgery itself rarely directly impacts the PVC burden, but likely does impact the complexity of the PVCs, especially if substrate such as scar is already present. Ablation of papillary and non-papillary muscle PVCs during mitral valve surgery appears feasible, though efficacy and safety needs to be established. And finally, in addition to standard morphology criteria, which we as electrophysiologists use, we believe that preoperative imaging, whether by MRI or hybrid PET MRI, may be useful for guiding the ablation strategy. Thank you.